Welcome to the Orthopedic Indications channel, where we discuss medical education for medical sales consultants and reps.
All right. So, 35-year-old female. She's had a previous bunion surgery. This was done 7 to 8 years ago, and that was a revision to so she's had two previous surgeries before coming in, right? She's very healthy. She's active. She works on her feet. She likes working out. I think she works in healthcare, if I recall, as well. So, she's got the complication factor is high. But here's her x-rays. So, what do you think? And we're talking about the left side.
Okay.
Wow. Yeah. It's a little
So two surgeries on the left and one surgery on the right. I don't have any history on the right.
So just before, I'm curious because I want to bring this up at some point. So is anybody using any type of joint replacement right now for the MTP? Like Cartiva, I mean, is that totally kind of fallen off?
I don't think it's fallen off. I mean, Tom and I were talking about this a little bit before you jumped on that.
Yeah.
I think it's something I'm very interested in. I think there's a lot of opportunity there. I think we just got to get it, get the implant right, get the indications right. There's definitely going to be a big interest in it. I think more and more patients are going to be interested in it. I think technology's improved. I was thinking about this earlier tonight that, with ingrown surfaces and increased wear.
So are you talking about
properties.
Cartiva? You're talking about the new
No,
like biopoly? And I have no.
maybe I'm talking about what doesn't exist. I don't know, but maybe it's like pie in the sky as much as anything. But I think with some, potential for better ingrowth surfaces and better wear surfaces, that there will definitely be an interest. I think you can get something right. I think that there would be an indication for it. But the things that I don't know are what are the soft tissues, the deformities that go through with it or go along with it. How do you manage the sesamoids in this situation? Those are some of the questions I have. So I'm not opposed to it. Like Tom and probably you, I didn't have much of exposure to training. I tried a couple implants, several years ago that were just okay, but not enough to make me switch from a fusion. Jan, Tom, your thoughts?
Yeah, looking at this X-ray, Nick, this was before my time, before even my time, but first generation ankle replacements, right? I kind of look at this left-sided X-ray and think, it's like a Gen 1, ankle replacement. It's just the design's not right. It's kind of wonky and it clearly fails. And I think if you kind of cut your teeth or develop your practice in a region where a lot of this stuff is being done in your community, if you see many of these X-rays, you're probably never going to put in an implant, right? And then but the truth, as you said, is probably more towards the midline where, with the right indications and maybe a Gen 2, Gen 3, I don't know, MTP implant. I think I'm interested in the concept. I think analogous to your comments. I think that for the right patient, it can be great. I just haven't had that experience.
And I want to be super clear that I'm not trying to. This is not I'm not presenting this case because I think this implant is terrible. I'm presenting it to how you manage this patient. In this case, I think that my understanding is if you go through and look at kind of what happened, I actually there's a lateral. But this is like the X-rays from 6 or 7 years earlier, and it looks like had probably some sort of distal osteotomy of the first metatarsal. And maybe what I thought maybe happened was developed AVN as a result. So it maybe it's not completely surprising that this might be the outcome if you are replacing the phalanx as opposed to the metatarsal head. So like I said, this is not something to say that I don't think arthroplasty is, has its usefulness. I don't know what the denominator is versus the number of failures we see. But I think the point of showing this is to say, hey, these are the challenges you manage in some of these cases. So those are the X-rays. How are you guys managing something like this? Bone loss. She's probably getting a little bit of metatarsal overload, second and third metatarsal overload. She's a little bit short. how are you managing this?
Yeah, really interested, as you said, in how they feel adjacent to the obvious disaster there, and trying to build in maybe some extra components of the surgical algorithm. Do we need a DMMO? That comes to mind. I'd probably get a CAT scan here, looking at sesamoid, looking at bone loss, looking at maybe kind of how much bone will be left after you potentially flat cut that. What do you think, Jan?
Yeah, I'm doing the same thing, and I think that just gives me an idea how cystic that distal phalanx is, so no surprises. And then, then it's like, what type of bone graft I mean, I use bone graft for this. Sometimes I'll use an allograft wedge, sometimes an iliac crest piece, go old school with the iliac crest, but just helps me with preoperative planning, because I think this is not as straightforward. I like these cases, because for me, this is the mesh between trauma and foot and ankle.
Mm-hmm.
So,
Mm-hmm.
but it's got to unite it two sides of the joint, so it's not just if you put a spacer in there, it's got to unite to that, whatever that spacer is. I've seen some people use even some other type of metals. I've not used any 3D printed implants for this, but I think that's a role here too. Makes sense to me, that you can get some on growth onto the metal right away with some like tantalum, or something similar. So
yeah, I guess I might be thinking about that as a revision to iliac crest. I would probably keep that in my pocket, especially given this patient's young age. And I feel like you've got one more shot to get it right before maybe you're going extreme with metal. I don't know. Again, I share your lack of experience there with that for this application. Does she look a little osteopenic to you guys? Maybe. I know she's young, and maybe that's just the radiographic.
Yeah, maybe maybe a little bit. It's always a little hard to fully assess, I guess. But yeah, I don't disagree with that at all. I totally agree with that. I've had some cases where I've been concerned about infection, where I've done a 2-stage, and then put a cement spacer in there for a little while, and almost a little bit masculé kind of technique. I've done that once or twice, which is kind of a nice option. Anytime you can take hardware out and then come back and do it as a single stage, it can be nice. So you kind of know what you're dealing with for bone loss.
Thinking about fixation there, running out of room a little bit on the distal end of that fusion, and interested to see what kind of plate construct you might have used for that.
Yeah, so this is all the things that I kind of laid out. Some of the challenges: scarring, surgical incisions, and trying to gain length is always a challenge, because you can affect the blood flow, and skin, ability to close skin in something like this if you're really trying to gain length. And then the role of lesser metatarsal osteotomies. For me, that one of my first exposures, Jan, you'll appreciate this, was when I went down to Jacksonville during our one of our rotations in residency, and worked with Dr. Whalen. And he wrote this back in 2009. He had a case that I was doing, and he had me scrub in with him, and kind of showed his clinical tip for interposition bone graft for first MP fusions that he had written up. And so I thought, or was writing up maybe at the time of that I scrubbed in. And it was just pretty cool to kind of see this and see the article come out, and kind of talk about using the cup and cone reamers to help prepare the graft. In this case, I think he was using allograft to prep that spacer. But certainly kind of I kind of think of this like a football kind of situation. This is Dr. Easley and Albert Anastasio. They're I think this is out of Foot and Ankle Clinics, and just some surgical techniques, but using the cup and cone reamers. I think in this case, we actually made the graft. We took iliac crest and we made it like a football because of kind of that defect that was in the first metatarsal. So it made it, the graft like a football, where you reamed with the female reamer on the graft on both sides, and then kind of dunked it inside there. This, you can do it, making it kind of shape it so you use the female on the metatarsal and the male on the proximal phalanx, and then you kind of interpose the graft there as well. But there's different ways that you can do it to try to manage bone loss, and then all the while trying to gain length. So this is what the construct looked like after the fusion, which I think I did this with one of my partners, and overall did a nice job of restoring length. There's the graft. Used fairly long revision MP fusion plate. Now they have some revision options, but getting a screw into the graft as well. And this is the final
really
follow-up.
Yeah, looks great.
Yeah, and it healed well. It's fortunate. I think the iliac crest is so powerful for healing, and surprisingly, these will actually do well. Jan, like you said, these are kind of an enjoyable case because it is a bit of mix of trauma and managing bone loss.
And they're usually so miserable preoperative, right? It's that always helps.
Yes.
Are you worried at all, with restoring that length? Obviously, did you run into any difficulty with tendon tension, or were you worried at all about the vascularity? I sometimes find myself wanting to get a little more, but maybe pulling up short because of those concerns.
No, I think part of it would just help that she was young and healthy without any comorbidities, but that's extremely important to ask about because a lot of times these are going to be older patients. Skin's not going to be as healthy. It's going to be scarred. Those are the things you really worry about. And, even thinking about, when do you let the tourniquet down in a case like this? Maybe you let it down before you put the graft in and kind of stretch it out and just make sure that each step of the way, you're not necessarily, you can kind of document at which point you are at that you might lose blood flow in that case.
What have you guys?
That's a great point.
What have either of you guys used? Like, for example, Tom, you mentioned, there's not a lot of distal fixation options, right? I mean, you can't use like a longer plate distally. What have you done in the past when you've said, okay, maybe I got 2 screws, 1.5 screws? Have you any tips or tricks?
Yeah, not really, especially if you're using a cluster plate like that. In terms of maybe augmenting with a long oblique interfrag screw, maybe from the medial aspect of that proximal phalanx, trying to kind of hit a home run. There's just a lot of traffic there, right?
Yeah.
I usually will try to get some type of cross screw fixation in addition to a dorsal plate construct, and certainly sometimes I've been unable to thread that needle, but that helps me feel a little better about maybe rotational stability of that interpositional graft. And again, a CAT scan, I think, to define how much room you have to work with sometimes helps me feel better about that preoperatively.
Yeah, and I think that's a great point. And using crossing screws can be helpful. If I get 2 across, I love it and then adding a plate. I think in terms of stability, that I really like that construct. But sometimes it's hard when you have the piece of graft in there and you don't want to displace that either. And but yeah, I think that's a great point.
Are you using any kind of biologic adjuvant there? Any BMP or anything expensive you thrown in there?
If I'm using iliac crest, no. If I'm using an allograft, I'll use like bone marrow aspirate, perhaps in something like that, or some other, off the shelf biologic. But Jan, are you doing anything like that?
No, I'll use autograft. I use BMP, in a lot of places in the body, but this is the foot though. Like MTP, I'm very hesitant. I don't think I have ever. I'm not saying I would never, but you get a lot of swelling from BMP and inflammation, and so I would just really be worried here about skin healing. When you're at it, you had the plate, you had the graft, you're already stretching this out. I've not seen it. That would be a concern of mine to adding like BMP in this area, or even in like for like a Liz Frank midfoot fusion. I've not used it. I've used it for hindfoots, subtalar non-unions. I've used it for, ankle fusions and everywhere else I can think of. But this is one place I've stayed away from it.
Yeah. Okay.
Great though.
Yeah, thank you. Good discussion on managing bone loss, I think. And again, I want to be clear that the goal is not to like trash any implants or anything or particular implant. It's just how do we manage the defect, when we see it. And I'm sure there's plenty they're doing well.
The other thing I would add, you just go back to the other X-ray. What I've done a couple
Yeah, of
times
course.
is I've done orthogonal fixation, like just keep that X-ray up. I'll put a 2-0 plate medially, not laterally. And put a couple of screws then proximally and distally just for a little bit more torsional control. Because usually you can put 2-0 screws across that distal phalanx. It's a lot of hardware, but it's another way to add a little bit of fixation if you're worried.
I like that a lot. Thank you.
What about I think that's a great tip, Jan. I like the trauma surgeon having the 90-90 plating. I appreciate those
right.
spots.
Yeah.
One other question: role of staples or more dynamic fixation. Are any of you using that for MP fusions?
Yeah, I'll jump in there. A while back, I kind of, I guess I'd say in my training, it just wasn't something I was exposed to. That might just be kind of a byproduct of my age and stage. And then as I saw some of that nitinol usage kind of ramp up, there's that product that kind of combines nitinol with plate, kind of staple compression plate construct, and that appealed to me. It seemed like a gateway drug to nitinol, where you could kind of get your staple plus some kind of standard plate screw belt and suspenders construct. And so I kind of got onto that before I went down the dark pathway of MIS.